Now going to move to work particularly in relation to DataCAN, the case study in terms of COVID-19 and cancer. And just to emphasize again, and you'll hear this later on in the session, in relation to patients are very much at the heart of everything that we do. They were involved in the original writing of the DataCAN grant. They're involved at decision-making at all levels of DataCAN, steering board, management group, etc. I can see they're involved in many different activities. And I just love this quote from Jackie, who's one of the patient advocates that we work very closely with within DataCAN. For me, COVID was personal. My uncle died of a COVID-related illness. And one of my colleagues, Edward Vidoliak, who's an oncologist in Croatia, reached out to me. And while he was sympathizing with me on my loss, he also shared this rather chilling statement. People are starting to fear a COVID-19 diagnosis more than a cancer diagnosis. Anecdotally, we'd heard the same thing. This was back on the 29th of March 2000 was when my uncle died. So right there at the start of the pandemic. But where was the evidence? So we initiated a data-driven collaboration between DataCAN and University College London, and you can see Alvina Lai and Harry Hemingway from UCL, who we worked very closely with on this project. And two aspects to it: one, looking at accessing real-time data from trusts across the United Kingdom, and the other looking at modelling excess deaths of the adverse impact of the COVID pandemic and the lockdown. Just very briefly then, just to share some of the key messages with you, we wanted to look at both the cancer diagnostic pathway and also the cancer treatment pathway. And so we looked at 2-week waiting time, which is an early warning system for suspicion of cancer. We found, and quite incredibly, 7 out of 10 people with suspicion of cancer were not getting referred at the appropriate time to cancer specialist services. In terms of chemotherapy, which again, a proxy of the health of the treatment pathway, 4 to 10 patients not getting their chemotherapy at the correct time. The modelling work that Harry's team led on with Alvina showed between 7,000 and 18,000 excess deaths, and there was an additional impact of comorbidities, particularly cardiovascular disease and hypertension, diabetes, and obesity and COPD. This is the first data really that drew attention of our government, academia, the NHS, to the disastrous impact of COVID, both on cancer services and cancer patients. Unfortunately, this disruption was felt right across the cancer pathway. This is work we did with Claire Turnbull, that she led from ICR, and also with Colonel Farrer. And also you can see here in terms of trying to model what's the impact in relation to 5-year survival. And you can see here again work we did with Colonel Farrer. You can see here the impact can be quite significant for colorectal cancer. It could have set us back nearly a decade. Again, other collaboration in this area that we've done. This is a very interesting piece of work that was led by Lawrence Lovett and Alex Ho from UCL. And again, looking at the rather disastrous impact that we can see there in relation to endoscopy procedures. You can see there a drop of nearly 90%. Really significant, may lead to delaying something in the region of 500,000 endoscopies. We also went at the European level, presented our data both to the European Cancer Organization and to WHO Europe. We were selected to co-lead a special network on COVID-19 and cancer. We rapidly brought together researchers and clinicians and patients from right across Europe, and it launched a 7-point plan for COVID-19 and cancer to really mitigate the impact of COVID-19, the pandemic and the various lockdowns. And you can see here a 7-point plan. Most important, address the cancer backlog, but also critically restore the confidence of European citizens. And I can see other important things there, and also that very important rapid deployment of cancer intelligence, really emphasizing that cancer can't become the forgotten sea in the fight against COVID. And following the summit, we were asked, would we consider running a campaign on the impact? And this is the Time to Act campaign that I have here also behind me on the poster. 2 parts to it: a data intelligence study to actually look at was what we're seeing in the UK actually being seen around Europe, so a Europe-wide study, and also then developing campaign messages and translating them into 30 European languages. This is some of the data, again, quite scary. You can see there, 100 million cancer screening tests were not performed. 1 million people may be walking around with a cancer diagnosis as a ticking time bomb that they're not actually aware of at the moment in relation to the impact on cancer diagnosis. You can see their treatment, particularly surgery and chemotherapy. Also, people less likely to attend either screening appointments or go to hospital or go to their GP. So again, how do we actually restore people's confidence? And also the impact on the workforce, 4 out of 10 with burnout, 3 out of 10 with clinical depression. This then underpins this data, underpin the messages of the Time to Act campaign. Cancer won't wait, so why should we? 3 particular areas of focus for the cancer patients and citizens. Don't delay. If you have warning signs, please go to your doctor, keep your screening tests, and also emphasizing that cancer services are safe. For the healthcare professional, you're not alone. There are a wealth of tools and also organizations that can support you. But most importantly, for policymakers, for healthcare leaders, and for governments, cancer services must be at the top of the agenda in terms of getting it back on track. We reckon that probably we need to be working at 130% of capacity to actually get back to a better normal. And we really need to address that cancer backlog now. We've already had 3 national launches. We first presented our data intelligence to the European Beating Cancer Committee in the Parliament on the 10th of May, then the official virtual launch on the 11th of May, and then there have been national launches in Poland, Italy, and Spain just last Friday. Also, this work received the Royal College of Physicians Excellence in Patient Care Award. And this is just the Time to Act campaign. So please don't let COVID-19 stop you from tackling cancer. Thank you. Now hand back to Monica in relation to her case study.
Thanks, Mark, for that very powerful presentation. I hope folks can hear me because I've switched over my microphone and because my headset was giving a bit of feedback. People will soon let me know if you can't. So my case study is very much around improving quality and access to cancer data, including through a national cancer trusted research environment, which I mentioned briefly earlier. So the way that HDI UK works is about uniting the UK's health data to make discoveries that improve people's lives. And I particularly like this graphic because it puts the health data research hubs right at the center. So the 7 HDI UK funded ones, of which DataCAN is one, and then the British Heart Foundation Cancer Science Centre, which makes 8. And this is very much bringing together, uniting the UK Health Research Alliance, mainly NHS organisations, but other national organisations, charities, etc., who have essentially signed up to the principle that sharing data for research is a good thing. And we essentially facilitate that through the Health Data Research Innovation Gateway, which is a publicly available asset. I would encourage everyone to go and have a look. Just Google it, and you can look at the hundreds of data sets that are actually described on there. And there are also a whole set of sort of tooling, data quality assessments, and sort of papers and projects associated with that. And underpinning that, it's very much throughout is about the patient and public benefit, and we'll hear more from Chris and Margaret later in the presentation. So DataCAN this is our vision on a page, putting the patient very much at the center. Cancer is a complex disease, as I'm sure you appreciate, and so we need to bring together clinical data. We need to bring genetic and molecular data, pathology, and radiology. And the aim really, at the heart of what we're doing is to improve that access to existing data, improve the quality of it, improve UK coverage, and add new data sets at scale, particularly around genetic, molecular, imaging, pathology, and then primary care and patient reported outcomes. And also, and you'll hear a bit more about this from James later on, ensuring fair value for that as well. So the metadata, the way it's described is there's a structural metadata catalog, and each data set has a very comprehensive description, but it also has all the underpinning data models, because as soon as researchers want to get into it, they want to see what the data is. And you can actually do excellent sort of assessments of whether it's going to be fit for purpose, whether it will meet your protocols, without actually having access to the real data at all. And that is one of the sort of the ways of expediting this and saving people sort of time. And I'm pleased to report that DataCAN has 14 data sets that are described on the gateway, all of which are rated gold or platinum. So one of the things we didn't expect to do was actually to be a data controller as DataCAN. But throughout the pandemic, and you heard from Mark, you know, what our sort of accelerated analysis was around excess deaths and the effect of comorbidity on COVID and cancer survival. We were asked by HDI UK Central to work with NHS Digital to develop the National Cancer Trusted Research Environment, TRE. So what this does is it takes routinely collected data sets, so things like hospital episode statistics, secondary uses service data, and the routine cancer data sets, such as the cancer outcomes and services data, the radiotherapy and the chemotherapy data sets, and then brings in all the COVID specific ones that were collected through public sort of interest information governance framework, COPI. So that's sort of pillar 1, pillar 2 testing. You'll have heard these terms, the GP pandemic planning data and medications data. And cleverly link those together using National De-Identification Tool, Privitar, so that the data in here is de-identified, but it is linked. And then approved researchers can access the area that they have got particular clearance to do through the data access request service, which we've been through. And that is all overseen by iGuard, which is the independent group advising on the release of data. So a lot of checking, governance and consultation around that. As part of the sort of the development of TREs, and this is articulated in the recently published data strategy that came out last week, which is out for consultation, which I would also encourage people to look at, is the concept of these 5 safes: safe projects, safe people, safe settings, safe data, and safe output. And you know, that's a high bar to sort of meet, but actually it is really important to make sure that actually what we're doing is appropriate. And there is a TRE roadmap with selected sort of deliverables. A lot of that is about the background work and the platform migration. So this is a cloud-based platform, so no data goes anywhere. So NHS Digital collect these things under, you know, sort of their governance as a non-departmental public body, and they actually have that legal basis in order to do that. But what the researchers get is essentially a role-based login to be able to see those de-identified data. And that's what we've been working very closely with NHSD and other organizations around. And you can see that cancer is the forefront of this with cardiovascular, and the cardiovascular hub led by Kathy Sudlow are already using these data. And we any day now will be getting access to the cancer data. So what are we planning on doing? This is essentially the description of our sort of research to enumerate the impact of COVID-19 on cancer pathways, but also doing a robust evaluation of the TRE. We feel that this is very much a collaboration project, that we will give as much as we take from the system. And we're looking specifically at both the direct and the indirect impact of COVID on cancer, and we can look at that sort of over sort of pre-pandemic, during, and hopefully when we get to a post-pandemic sort of phase, and that we actually see the recovery as Mark's just described, seeing what those sort of patterns are and prove that actually some things are working and other areas that we need to focus on. And finally, this is the sort of the utopian view of where we really sort of want to get to. So I've described the gateway and the process of discovering through searching metadata, getting access through signing up and data access requests, analyzing, and then communicating and publishing results. And there are a lot of sort of easy to access sort of use cases that are also available in a number of videos on the website. You know, the NHS Digital TRE is not the only one. The folks in Wales will tell you that their SAIL data bank has been running for many, many years and very, very, very effectively. So there are lessons to learn from other ones. But the aim is that actually by using the technology and the infrastructure in a very sort of innovative way, that we can create a sort of TRE to TRE environment that actually we can ultimately get to that UK-wide picture in a federated way. And that all of the data doesn't necessarily need to be in one place, but it needs to conform to the standards and have that interoperability. And I'm very excited about it. I think it's a huge achievement. It's something that we've never managed to do. And I've been working in this industry for a lot of years and have been aspiring to this. So thank you very much for your time. And I think I'm going to hand over to James.
Excellent. Thanks very much, Monica, and thanks everyone for joining today. Pleasure to talk to you all about health data as the key driver for research and outcomes. And I think just to share why that's a real core belief within DataCAN is that data is now, and you've seen from Mark and Monica's descriptions, data is now much more recorded and digitized than it's ever been before. Healthcare research is resolutely expensive, especially when we get down to finding those small groups of patients that are needed for precision medicine. So we really, really need to do more data science and make the most out of the data that we're already collecting. And on top of that, the private sector of health research is at least as big as the public sector, and they're the ones who are pushing forward the drugs and devices of tomorrow. So we need to find a way in which we can work with the private sector and commercial companies to do patient-approved health data science. And that's really what my job is in DataCAN, and one of the things that we're trying to do in DataCAN. Next slide, please. So in terms of how we want to work with industry, as I said before, it's got to be patient approved. So within DataCAN, one of the rules is that for any commercial piece of work, patients review and have the opportunity to say no to all of our commercial proposals, and patients review and have the opportunity to say no to all of the contracts we do. So we can be sure that everything we're doing is patient approved. Touching back to what Monica said around the HDI UK principle of participation, we need to make sure that the access that anyone gets and the terms they get have to be fair. We need to make sure that everyone is sharing equally in the benefits that come from this health data science. There are a bunch of key issues we know from industry engagement that we're trying to solve. One of those is around the speed of data access. One of them is around the predictability, and one of them is around the quality of that data when we actually work on it. So the sorts of projects we do can be advisory, they can involve data access, they can involve data curation when we take a data set and go back into the unstructured record to improve the quality of that data, and all credit to the Leeds and the Edinburgh teams who've been doing this. And then the classic data analysis, which tends to be the bit that seems most important, but is generally the minority part of the work, when you take a good data set and then you work out what does this mean for patients on a day-to-day basis. So we've been working with companies, like I said, advisory, delivering data access and service projects. And we also work on long-term partnerships, such as the one we have with IQVIA. Next slide, please. So this is a recent example of a data science project we did with Roche. They're the big pharma company. And this was focused on a type of cancer called triple-negative breast cancer. And triple-negative breast cancer is a subtype of breast cancer, which unfortunately does not respond to most of the drugs that are used for the other types of breast cancer. And therefore, it's a type of cancer with a lower survival rate, and one where we really need research to improve the treatments that we have. Now, Roche is looking into this. They have some drugs coming through for breast cancer, and particularly looking into early triple-negative breast cancer. And when they came to us with this project, they had a pretty tight timeline. And as we always do, we went out to the patient group, and you'll see what Jackie said at the top of that. But what I didn't put on the slide, and it was really the heart of the patient group's feedback, was we know it's going to be difficult to do this, but we need you to find a way to do it. You may not think you've got the time, but early triple-negative breast cancer is a terrible problem. We need you to help. So with that guidance, we tried to help. And what we needed to do was understand how we could access data from the NHS about patients with early triple negative breast cancer, so we could understand what the interplay was between the treatments they had and the outcomes they had in such a way that preserved their privacy. We did quite a bit of work with breast cancer clinical experts like Peter Hall from Edinburgh, data creation experts such as Sue Cheeseman and Nina Snelling in Leeds, to really understand what we could do with this data. And what we realized was not all of the data was good enough. So in the structured record, which is the kind of digitized bits, not all of the patients had fully recorded whether they were triple negative or not. So we need to go back in, and again, credit to Sue and Nina for doing this, go back into the clinical notes and extract from those handwritten notes or free text notes actually precisely what the node status of the patients were. So quite a lot of work done on patients, both in Edinburgh and in Leeds, again, behind the firewall. Customer didn't see any of this. So once we had this good quality data, we extracted that out into a single data model that we knew would answer the question. And the critical question was around the linkage between pathological complete response, which is after you've had your initial cycle of chemo to shrink down your tumor before you have surgery. Some people have pathological complete response, which means that the tumor effectively appears to be largely gone away. What we're trying to work out is that pathological complete response then linked in the long term with overall survival? So what is the link between these two? And that allows a better choice of drug or other sorts of treatments after the pathological complete response is recorded. So we're trying to find that link. We extract the data from both Edinburgh and Leeds that we've already got back up to the quality we need it to be. We link that, anonymous data at this point, no names or identifiers on it, in the secure environment, which is up in Edinburgh. We do the analysis, and all thanks to Giovanni Tremonti for doing this, and then presented this back and discussed it with the Roche scientists. Obviously, lots of questions around what's the quality of the data, anything coming up around treatment patterns and the rest of that. But the great thing is that because we did all of this behind the NHS firewall in the original electronic health records, that all of the data improvements and any of the insights from it are immediately available for clinical care and for academic research. So great thanks to the whole team for doing this. And also thanks for Roche for trusting us. It's a piece of work we hadn't done before. So it was a demonstrator for both sides. Next slide, please. Another example of a piece of work we did, and this was very patient-focused, was with Flatiron Health. And Flatiron Health is a American cancer data company that effectively is trying to build up a large database of how cancer patients do in the real world. They've mainly been focused on the US to do this. And what they do is they send in a team of data curators, people who improve that data quality, to a quality that's high enough that it can be used for decisions around the approval of new therapies through the FDA in the US. So Flatiron, mainly in the US, was thinking of coming into the UK. They didn't really know the UK, and therefore they knocked on our door and said, "You're the cancer data specialist in the UK. Can you help us understand how we should be approaching patients and hospitals and clinicians?" And so we did a review of their value proposition in the UK. And one of the biggest things we did there was to pull together a group of patients from our own PPI group, and these patients are shown on the right, to really go deep in what Flatiron was proposing, because it's about commercial data access, therefore potentially controversial. And I was really grateful both to the patients for taking the time, but also Flatiron for taking the time and the perception of risk, because certainly the first meeting was pretty challenging, frankly. A lot of the patients didn't really understand what was going on, had some very kind of basic and quite stretching questions around what was this American company doing over here, what access to data they would have, and the rest of that. And both the patients and Flatiron pushed through that. We had another 2 meetings after that, and really positively came out with actions and ideas about how Flatiron could improve what it's doing and how it talks about what it's doing. And really delighted to say that they have taken this on, they have changed the way they're doing things, and they are in the process of putting together their own patient engagement program and their PPI group. So cancer data access, really, really essential for science, and you really need to make sure that commercial access is possible as long as it can be patient improved. What we've been doing in DataCAN is trying to find ways of doing that. And I think the Edinburgh Leeds model, which is one where the identifiable data is behind the firewall and the results come out, is one way of doing it. And the Flatiron one is another one, which is really making sure that patients are not being consulted after something's gone wrong, but they're being consulted at that early phase when people are doing their planning. I think that's it, me for slides, but just check the next one. Yeah. So this is a just quick summary in terms of the first kind of 18 months with industry. And the most obvious thing is that we are not a kind of a global commercial research organization. We are a hub that's really focused around patients, really wants to integrate with the NHS. And I think that has a difference in the way we behave with commercial companies. That, as I said before, patient involvement is possible. It does take time, it's challenging, but it really needs to be done properly. And what we found is this tends to lead with longer term partnerships. We're continuing to work with Flatiron, we're continuing to work with Roche, for example, but that really helps those longer term relationships. Under COVID, obviously, the priority for the NHS has been patient care. So we really need to be clear that if patient care needs to take priority, then it does. So we need to be very clear about how we can manage the timelines for our data research projects. But it is absolutely worth doing it. The data and the services are very, very valuable if we can find a way to unlock it. And to my mind, industry work is key to this. And I've been able to find ways in which patients approve that, and I think we can continue to do that. So thank you very much for your time. Happy to take any questions.
Thanks, James. We're now going to move into breakout rooms. Hope that's okay with everybody. So we've randomly assigned you to 3 breakout rooms that will be hosted by our 3 speakers. So James Peach will be in room 1, Monica Jones will be in room 2, and Mark Lawler will be in room 3. So we've got 10 minutes in the breakout rooms looking at these 2 questions. So what are the barriers that you face in sharing or accessing cancer data? And how can DataCAN work with you to solve these?
Those breakout rooms and breakout sessions, I was in number 1 with James, and that was certainly a great discussion. We've got just less than 10 minutes to do some feedback with the chairs, and I'm really just here to introduce them in order. We'll go in a reverse room order. So we'll go Mark, then Monica, then James, simply because Mark has to leave early. So if Mark's available there now to do your feedback, just 2 or 3 minutes, please, Mark.
So I've just put, can you see that on the screen?
Yes, we
can. So yeah, I've just put up just in terms of the 2 questions, so the barriers and then sort of solutions, if you like. So first one was risk aversion, and particularly for larger organizations, feel vulnerable in terms of potentially sharing data. Obviously, there's been some media attention as well. So it's looking at having much more of a culture of transparency, but that also allows people not to just become rigid in terms of the ability to share or access data, but that transparency is very important. The other thing that was brought up was sort of technology. So you know, there is a degree of risk in terms of sending something, and also the potential that it might be, as Chris said, a file and forget. That, you know, sort of we want to know what the data is being used for, not simply that the data has been transferred or shared between individuals. And I know particularly patients talk to me a lot about that in relation to, I'd like to know, you know, how did my data contribute? And we're not very good as an NHS at feeding back information to patients as to what their donation of their data actually achieved. Understanding the principles of sharing data sometimes can be a challenge, and that needs to be, you know, there needs to be reassurance to all stakeholders in that, and also better communication. Mixture of understanding between the UK position and the Northern Ireland position, for example. So different jurisdictions may have subtle differences in relation to how data is shared and analysed. So we need to make sure that it's not necessarily always that one size will fit all. There may be nuances we need to address with. And then the other thing is governments are not very good at making long-term decisions. So we need to work in partnership with them to say sometimes you need to think about these things, you need to try them out, you need to test them first, and then bring them into the sort of, that they become policy. And then just in relation to some of these I've already covered, but be proactive in how data is used, rather than reactive to a media story. So we need to be much more proactive with, you know, what we are doing, and also how we communicate that. And then also, it's also important that the trustworthiness, as well as being obviously with the public, but also with practitioners and with different organizations who you're working with, and don't necessarily just take that for granted. And the feeling was that DataCAN could help in a lot of these situations in terms of being the honest broker, if you like, in these discussions. Okay.
Certainly. Thank you. That's great feedback. Thank you, Mark.
Okay.
On to Monica,
No,
please. Thank you. On to Monica from room 2.
Thanks, Helen. I don't type as quickly as Mark, obviously. So I've got mine on a little bit of paper. There we go. That's the old-fashioned way of doing things. In terms of the barriers, the things that we sort of focused on was around governance, information governance. The group were keen to know what can be shared and what is essentially the legal basis for this. And we talked about the opt-out process, whether at a national level or at a local level, and how that sort of works. I think one of the other barriers that was sort of raised was that we're still feeling, the effects of the pandemic. We're still right in the heart of it, and the focus is still very much on COVID, particularly from the front line of the NHS, and we've got to recognise that in terms of what the realistic sort of expectation can be for colleagues who are still working on that. And how can DataCAN help? I think there was sort of 3 things. Not unsurprisingly, improving the timeliness of data, that folks wanted to be able to know how to expedite that. And help with sort of speeding up the access. That doesn't mean that we cut out any of the governance loops, but as I explained to our group, DataCAN's only been around for 18 months, but those of us who are a part of DataCAN have been in this business for a lot of time. I've actually still got hair, unlike the rest of my colleagues, and understanding sort of what is available and how we can access that. And once again, please just come to us. We do these outreach sort of sessions, but actually we're very welcome to any kind of request, and just sort of come to us, and we'll see what we can do together. So that was the feedback from breakout room number 2.
Fantastic. Thank you, Monica. And last but by no means least, over to James in room 1.
Thanks very much. And also thanks for all those people in room 1. I started going around some names, so I did miss out some people. So apologies for those, and please do put any further thoughts or questions in the chat or to me directly. Really interesting kind of review, because we went off agenda, to be honest, and talked about the things that we were interested in. And there was a great point right at the beginning, which is that I think that, well, what we heard is that we can be clearer in DataCAN and HDR UK around our priorities and exactly what we're doing, because we are doing so many different things, really understanding kind of what the heart of it is. And I think coming back to Monica's slide, the work that Monica is doing around assessing and evaluating the cancer TRE by working out how we can understand the impact of COVID on cancer services, that's a really nice example. And I think we need to be able to share these examples clearly so people know exactly what we're doing. There was an interesting point around the role of industry in health data access still being unclear. And I think that's absolutely right. And I think that's the natural balance between industry being so important in health data research, but the UK population, the NHS, being quite nervous about how industry gets in there. So it is not completely clean. It's not completely finished. And so I think we're going to have to bear with us, because we are working out how to make this work. Then talking about the science, there was an interesting point around rather than trying to do all health data and make everything better, really good to understand actually what's the key objective we're dealing with. So thinking back to Mark's piece of work around how can we make sure that the NHS recovers from COVID in terms of cancer services as quickly as possible, and how to be act on cancer in that way. It's rather than doing everything slightly better, it's finding one key question and then pushing forward on that. And then a follow-on point from that was a very interesting one, which is that even if you do know that data science question, it can be quite difficult to understand whether DataCAN, HDR UK, or the data can answer that question. And I think that's absolutely right. We're not dealing with a completely standard sort of product or service which has been done 1,000 times. The data comes in shapes, it comes in qualities, it comes in standards, and therefore it's really important to engage with your data provider, be it us, be it somebody else, to understand whether your question actually really fits the sorts of data we can get in the UK at the moment. And sometimes that will be yes, and sometimes that will be no. There was a point in terms of does the data fit, is how can we deal with small and medium-sized enterprises. We are clearly very, very keen to do this. Our funding comes from ICSF, and they're very keen to see UK SMEs grow. So always keen to hear and engage with SMEs about their data needs. I mean, I'm a director of 2 SMEs, so I know the last thing you want to do is waste your time with us. So we will be as quick as possible in telling you whether it can't be done, and the sort of pricing and risks around it. So please do come and talk to us. And David finished off with a very nice pointer from the patient angle, which was looking at an area where data has historically not been very good, which is recording and access of data in care homes. And I think it's right to bring this up. It's mentioned in the NHS data strategy, and I think as we get better at understanding the value that data can have to us as researchers and patients, we get better at saying, well, why don't we have good data over here or there or there or there? And I think it's great to have that thought to know that the work we do is only ever as good as the data that is entered in. So let's make sure we get good data across the whole piece. So thanks very much for everyone in room 1.
Fantastic. Thank you, James. So hopefully that's given plenty of food for thought for Chris, who's going to take us into a conversation with Margaret Grace.